Hello, welcome everyone to this fifth keynote session of the International SPX Colloquium 2021. I am Katrien Zenner, member of the board of Shared Patient Experience and your online host today. Each of the past keynotes has greatly inspired us, covering a variety of topics: patients' expectations as a driver for change, transforming the human experience for patients, our workforce and the communities we serve, best practices on how to involve patient-citizen partners in research and care improvement, redesign care back into society. For those who missed one or want to revisit a keynote, you can find the videos of past sessions on our website, spexperience.org. Today, it is my great honor to introduce Professor Helen Ward. Professor Ward was trained in medicine at Sheffield University and is currently a clinical professor of public health at Imperial College London and an NYHR senior investigator. She has 3 decades of experience in research, education, and applied public health, and in the development of participatory approaches in health research. During COVID, Professor Ward was involved in several research programs. Today, she will share with us the results of a large study in England, Reactancovid, which combines in-depth biological research into disease mechanisms with participatory research, with patients to refine definitions and define outcomes. It is remarkable how patients suffering from long-term and highly variable consequences of COVID have found each other through social media, thanks to the hashtag #LongCovid. Thanks to this patient's activism, the condition of long COVID emerged and continues to be defined. Professor Ward, let me start with the first question. What kind of people become involved in these groups, and how were they able to get such influence?
Hi, thank you. What kind of people get involved? Well, I think initially a lot of the people who got involved in these groups were actually, well, there were people with experience of an unusual and emerging disease, but also some of the early people were actually also themselves scientists or clinicians, and they had quite a big influence on what happened later. So, but then it spread out to a wide range of people in different countries, as I'll show in my talk. So I'm ready to start if you'd like me to share my screen, if that's okay. Okay, can you see my screen now? Okay, thank you. So thank you, Catherine, and thank you to the organisers for inviting me to do this. As Catherine said, my background is as an infectious disease clinical epidemiologist, as well as an advocate for participatory approaches in public health and clinical research. I'm also a public health educator. When the COVID-19 pandemic started early last year, right early on from the end of January onwards, we started to develop research, education, and advocacy with a particular focus on the importance of community involvement and engagement in order to try and address the pandemic, whether it grew into the large one that we see now, or even if it was a more localized outbreak as it was in the early days of January and February. And in this talk, I want to share with you some of the work that we've been doing over that time, how input from patients and the public has been invaluable, both in the development of the concept and the knowledge about long COVID, as Catherine's just described, but also in my own research and work, and some early findings from our research on long COVID. My talk will essentially be in 3 parts. The first about the development of long COVID as a patient-led notion. The second will be about our own research findings on long COVID. And then the third about how we have tried to embed patient and public involvement throughout our work. I will thank my collaborators at the end, but I did want to say that the last year of research and work in this area, working with patients, the public, and other scientists, has been some of the most inspiring team science and teamwork that I've ever done, and it's been a privilege to be involved in it. I'm going to start by sharing an early call from patients for their experiences to be recognised. What I'm showing here is the Facebook page, the Long COVID Support Group. And as early as March in 2020, there were signs that many people were experiencing ongoing symptoms after the acute phase of COVID-19, including some people who had mild initial illness, as well as those with severe and hospitalization illness. People started to link up and find each other in various ways to share their stories. Some people, it was in privileged positions, I suppose, journalists who were able to share their stories. Others, it was through reports on social media. And the Facebook, well, what became the Facebook Long COVID Support Group was established on the 2nd of May last year by Claire Hasty. And I'm going to show you a video that was released in July, which I think tells you the some of the message. I'm just going to switch onto my screen and hopefully you will hear this. It's only a 2-minute video.
We're all members of a club no one wanted to join. Different backgrounds, ages, experiences. Thousands and thousands of us have been struggling for weeks and months with ongoing symptoms of COVID-19. These are some common symptoms, but there are many more. Some of us have been ill throughout, with others having relapses. We're still very ill.
Helen,
We're feeling
we cannot
pressure
see the
to
movie.
return to work, to care for families, and
you can't see it.
No.
It worked last time.
Yeah.
Let me see if I can do it this way. Hang on. This is why you test things at the beginning and then it doesn't work.
It's always like that. Right, can you see the thing now? Yeah.
Let's see if you can hear it. Is that working?
Yeah, perfect.
we're all members of a club no one wanted to join. Different backgrounds, ages, experiences. Thousands and thousands of us have been struggling for weeks and months with ongoing symptoms of COVID-19. These are some common symptoms, but there are many more. Some of us have been ill throughout, with others having relapses. We're still very ill. We're feeling pressure to return to work, to care for families, and get back to normal when we still feel anything but. No one seems to be able to answer our questions or give reassurance. Will we ever get better? Will there be long-term repercussions for our physical and mental health? Is this post-viral fatigue, or are we still infectious? Will I be able to do the things that make me happy again? Can we hug our loved ones, or will we make them sick? Is this damage irreversible? Am I going to die? We just don't know. So we're sending out an SOS. Each of us has our own journey, but lots of us are feeling abandoned, dismissed, brushed off, ignored, and given conflicting advice. It can be hard for those around us to understand how ill we are. It's confusing and scary. Our numbers are growing and we need to be taken seriously. We need rehab, research, and recognition. We need to be believed, helped, treated with compassion, and supported by those around us. Please hear our SOS.
Okay. So in that video, I think it's very clear what quite what a range of symptoms and how important it was for people to come together. This sharing of experience and making visible the range of long-term outcomes actually was very influential in leading to the consolidation of the notion of an illness called long COVID. And Callard and Perego, who this is a quote from an article in a research article in Social Science and Medicine, report how patient voices were able to consolidate around the hashtag long COVID after they started reporting these symptoms, including in people with initially mild disease. And they expressed the frustration in these early days. Patients, as you heard in that video, expressed frustration about people not believing them, not accepting, and dismissing their concerns. So lots and lots of people from different backgrounds in different countries started to join these groups and share their experience, share their frustration, and share their fears. Of course, with an emerging disease, there were no answers. And this, from my own experience, took me back to when I started as a clinical researcher, which was in the 1980s with HIV and AIDS. And when we first saw people who were diagnosed with AIDS in the mid-1980s, we didn't know what the future held for them. We did know that a lot of people died. We didn't know whether everybody died. We didn't know how long it would last. And once we had a test, we didn't know whether some people would continue to stay well or everybody would progress to AIDS. In that period, it is absolutely critical to develop strong allegiances and partnerships between clinicians, patients, and researchers. And I think that's what I'm hoping that we're seeing now with long COVID. This hashtag got to be used really extensively, and now I just looked today that this is the last 7 days use of the hashtag long COVID. It's become really ubiquitous. So this is on Twitter, 35,500 uses of it, and this thing at the bottom shows sentiments, whether they're positive or negative, all generated by artificial intelligence, no doubt. This shows the context in which it's raised and discussed, and you'll see these chronic fatigue syndromes and ME, which are syndromes where people have reported some of the similar symptoms as long COVID. Is quite dominant. And there's also a lot of concern we know about the possibility of the way COVID persists in some children. And this was just who it is that's tweeting about this, and slightly more females than males. But interestingly, the top occupations were authors, teachers, and health workers, which we certainly know that health workers are particularly concerned, both as professionals, but also as individuals, to be suffering from long COVID. So I think we would accept certainly the claim that this can be considered the first illness to be consolidated by patients, as in this quote from Callard and Perego, that has happened because of the ability to connect on Twitter and other social media. But I want to just move on to what is it and how common is it? So the first question of how common is it? This particular slide here is from an UK NIHR, National Institutes for Health Research, evidence-themed review, the second they've done, excellent summaries of the evidence to date. And this showed estimates of how many people get long COVID. And they found a range in, I think, 27 publications between 2.3% and 91%. And in trying to explain that, they looked at whether the studies had only looked at hospitalized patients or only intensive care patients, or people in the community. They had different definitions of how long symptoms persisted for and whether they persisted or there were new symptoms that started. And then they assessed the bias there might be. And the thing is, if you only base your findings on people who contact you with long COVID, you're going to find a high proportion, obviously. What you need is a more balanced and inclusive sample of people who've recovered as well as people who haven't. But these are quite difficult things to do. This is from another systematic review by Sandra Lopez-Leon, I think was published in May on medRxiv. And well, first of all, there's these long COVID hasn't got an accepted definition yet. That's important. And as it's emerging, I think that's correct. We need to know more about it before we start to constrain it. But these are some of the other terms that have been used. Long COVID has mainly been used by patients, chronic COVID syndrome, post-COVID, long-haul COVID, or more in the US, I would say post-acute sequelae of COVID-19 or PASC. On the right here, I show I think they found at least 55 different symptoms that were recorded in the literature on long COVID, affecting multiple organ systems across the body. And I think that shows the range of problems that people are suffering from. Before moving on, I think it is important to think about whether or not you consider this to be a single condition. And until you have a definition, of course, what you're looking at is a description of people with different experiences, which is why it's so relevant to this colloquium and talking about patient experience. Is it a single condition, long COVID, with lots of different expressions? Is it a cluster of symptoms and syndromes? Or is it just a set of individual symptoms? And on the one hand, from the purposes of creating a patient movement, an advocacy movement, retaining an idea of a single condition that needs attention, that needs research, that needs support, then keeping the solidarity of a single condition, long COVID, actually produces a stronger platform from which to advocate. However, if we want to better understand biology and understand what exactly patients need in terms of investigations and therapies, and if we want to start to develop new therapies, we need to break it down if there are indeed different pathologies going on. And so I think both keeping it as an umbrella term, but also being open to using different clusters is something that we need to work with as researchers. We need to work with patients to find the best and most meaningful way of describing these syndromes. There have been attempts to do this. So this is from the first of those NIHR themed reviews in October last year, which suggested that within long COVID syndrome, there were possibly 4 areas: post-viral fatigue, which would be similar to other post-viral fatigue syndromes, fluctuating system syndrome, people with lasting organ damage who would have ongoing symptoms because, for example, people who had severe respiratory illness, many of them have been found to have fibrosis, for example, in their lungs. Others have cardiac abnormalities, thrombosis, and some signs of brain involvement in other people. And then there is an accepted post-intensive care syndrome for people who've been severely ill, which includes, amongst other things, there's a physical side of that. There's also a lot of psychological and post-traumatic stress in people who've had severe illness like this. So I'm going to show you another very short clip. It's an extract from a Royal Society webinar, which was actually something that my colleagues and I were involved in, but it brought together people to talk about this I think it was in May this year. And there was about 1,000 people at this webinar, and it was hosted by Brian Cox, who's a physicist and former rock star, those of you who know him. And speakers included Nisreen Alwan, who's an epidemiologist who we work with, and who supports our work, which is great. And she has long COVID. And Adam Rutherford, who is a geneticist, who is also living with long COVID. 2 other speakers are Paul Elliott, who is the principal investigator in our own study on COVID, and Nish Chaturvedi from a similar study at University College London. So I hope to get this playing again.
We've got one question for you. So if you look on Slido now, you should see the question, which is, what do you understand by the term long COVID? And you can type a word in there, and we're going to make a word cloud of that to get a sense of what you understand about that condition. And that's really where I want to start with the panel, by asking what exactly is long COVID. I thought I'd go to Nisreen to ask that question, particularly if there is an accepted medical definition of long COVID.
Thanks, Brian. So yes, the problem is with your word exactly, but that's a problem. We don't have a universal specific definition of long COVID yet, but I would still define it as not recovering, so not going back to baseline health, so the health that you were at before COVID-19 infection, and the time for that really depends, and people define it differently, but usually, I would say for more than 4 weeks. So if you don't go back for more than 4 weeks. However, it's important, just to mention quickly that NICE, so we've got some clinical guidelines, and they recently, and they say that they break it down. So they say you've got ongoing symptomatic COVID-19 if you have symptoms between 4 to 12 weeks, and then you could have what's been called in the guideline post-COVID-19 syndrome, which is signs and symptoms consistent with an infection for more 12 weeks after the infection, if there's no alternative diagnosis.
So it's, roughly speaking, you should have expected to recover to a large extent within about 12 weeks. If you haven't, then that could be defined as long COVID. That's right, although it could be sooner than 12 weeks, depending on what you call it as well. For example, the recent statistics by the Office of National Statistics use a cutoff of four weeks for their question about whether people have long COVID or not. So it depends. And I think I should just ask you, and then Adam, because you've had personal experience of it, to very briefly describe what that experience has been. Adam, do you want to go first?
Yeah, sure. I mean, so, as I mentioned, I got COVID mid-March 2020, last year. I was a COVID hipster, before it became fashionable. And I got it pretty severe. So this was at a point where people were talking, and indeed I was on the radio saying, it feels like a mild flu. And then about a few days later, I was very close to being hospitalized and should have been hospitalized. I had a secondary infection on top of that. I don't need to go into too much detail about it, but was treated successfully, and in the sense that my COVID symptoms were alleviated. But it's now more than a year since then, and I still have lung difficulties. Now I'm 46. I was pretty healthy for a 45-year-old this time last year, of the symptoms that people with COVID and with long COVID have, of which there are many, really now I only have tightness in my lungs. So my upper respiratory tract. I'm talking to you from my bedroom, in fact, which is on the 3rd floor of our house. And I can't get to the top of the house without having to sit down and being short of breath. Now that's not right? That is not a return to how I was before. I've been doing plenty of exercise and doing as many things as I can to recover properly, but there's something in my lungs which isn't shifting. So that is common with lung infections. There are other lung infections which take a long time to recover from. And because we're only a year into this and a year into my personal symptoms, it's just difficult to know what is actually going on.
Okay, so I played that just to show, one person's experience of that, but also Nisreen's starting there with some of the definitional issues that we have. So in this first part, I would summarize that the challenges we have is that we don't have a clear definition and limited understanding of the biology. And that means we have little quantification of long COVID. The strengths, I think, of where we have been to date is that we have got extensive documentation of the varied experiences, because this has been led by patients and patient activists, and this strong patient movement. Many people have shared their experiences, have not been willing to be pigeonholed into, oh, this is post-viral fatigue, or this is one or other things, and that they have been listened to. And this movement is now advocating for resources, research, recognition, rehabilitation. So I just wanted to kind of pause there and see if there are any questions. I can stop sharing my screen for a while and hand back to Catherine for pause before I go on to talk about my own research.
If somebody has a question, you can raise your hand or put it in the chat. For now, I don't seem to have any questions. Maybe just, I was wondering, Helen, do I get it right that women seem to be more at risk than men for long COVID? And would you have any explanation for this?
Yeah, it's interesting actually. And I think although we heard there from Adam Rutherford, if you looked at those pictures of the multiple people who came together in the Facebook campaigns and so on, a lot of them are women, and a lot of attention has been paid to the fact that there seem to be a lot more women of sort of middle years, so women in their 30s, 40s and 50s perhaps. And if you think about COVID as a whole, COVID has had more severe effects on men, both the likelihood of getting infection and the severity of infection and the mortality have all been worse in men than women. So there's something very interesting going on here. And it does seem, and I'll show in a minute, that we certainly in our studies have found that women are more at risk of getting long COVID than men. And we don't understand the biology. It is probably in part due to different immune responses, with women having a higher antibody response early on in COVID, and maybe in some that leads to some abnormalities of other functioning. So there's some links to autoimmune diseases, for example, and then other people report, changes in menstruation. And so it may be that there are it's almost certainly there's a combination of reasons why women are more likely to report this.
Okay. Thank you. For now, there aren't any questions from our attendees, so I suggest we move on to the second part.
Okay, thank you. Okay, so I'm going to talk now about the study that I've been involved in over the last year. Actually started in May 2020, which was a study it's called the Real-Time Assessment of Community Transmission, REACT. And the study, I'll describe the study as a whole and then see how we came to do this sub-study of persistent symptoms. What we were trying to answer in the sub-study is really what I've been talking about to now, which is it's poorly understood and we don't know how many people get persistent symptoms, who's at risk, and what are the patterns of co-occurring symptoms that might give some insights into these different underlying syndromes. And also most of the published study, or many of the published studies, have focused on hospitalized cases. So the REACT study that this is based on is a community-based study. So it's been going on for a year, and it's a study of the prevalence of SARS-CoV-2, the virus that causes COVID-19, in the community in England. And we do this by taking a random sample in REACT-1, which measures PCR testing, uses PCR testing to measure the prevalence of the virus, and REACT-2 measures antibody. But both of these linked studies they're done in different people, but they're done in a random sample. And each month in React1, we test between 100 and 150,000 people. So these are very large studies. So overall, we've had well over 2 million people involved in these studies over the last year. Just to summarize some of the findings that we've had to put the long COVID work in context, React1, it reports the prevalence of the virus over time. And these are in randomly selected people. So it's not subject to the biases of people presenting for tests who've got symptoms or presenting as cases in hospitals or with GPs. React1 was able to identify the start of the second wave in late August 2020. It was one of the first indicators of how widespread that was. Identified the rapid rise in late 2020, and which was linked to the impact of a new variant and subsequently other variants. Tracking the decline during lockdowns, so it helps to assess the impact of interventions. And we've also used it to look at symptom profiles. What are the symptoms for people who test positive compared to negative in the community? React2, which I've been more centrally involved in, we used home testing, so people did finger prick home tests. So because we didn't want to have to get people to testing centres in the middle of a pandemic, and we were able to measure the prevalence of cumulative prevalence of infection. So how many people had any signs that they'd had SARS-CoV-2. And the first time we did this was in June 2020, so after the first wave in England, and we'd estimated that about 4.4 million adults had been infected, which was a lot higher than had been revealed because we had very little testing in that first phase. We also showed how antibodies appear to wane over time in the population and who was at risk. Particularly, we were able to show some of the inequalities by occupation, by ethnicity, by age, and by deprivation. Most recently of all, we've shown the impact of early vaccination rollout on antibody positivity in the population. So this long COVID studies, what we've done is each time we go out to people and ask them to test themselves for antibodies, we also do ask them to complete an online or telephone questionnaire. And so we took data from over 500,000 people in the rounds between September and February 2021, 3 rounds, in order to estimate the proportion of people. So everybody who is asked, do you think you've had COVID? If people say, yes, I think I've had COVID. If so, what symptoms did you have? And people are asked to say for each symptom, how long it's lasted. So this study, which was published last Thursday, and it was pre-printed last Thursday, was just over 500,000 randomly selected adults aged 18 and above, asked about their history and the presence of 29 different symptoms. And we used various analyses to identify the predictors of persistent symptoms for 12 weeks or more. And then we did a cluster analysis to identify people who had co-occurring symptoms, so groups of people that had similar patterns of symptoms. The questions, mostly closed questions like this, we did have some open-ended questions, but did you think you had COVID? When did your first symptoms start? Which symptoms did you have of the following? Were your symptoms overall mild, moderate, or severe? And how long did these symptoms last? So overall results of this 500,000 people, just under 20% reported they did think they'd had COVID with symptoms. So 1 in 5 of the population think they'd had COVID. The proportion that were symptomatic, so we then looked at those who were symptomatic, this 92,000, but had been symptomatic at least 12 weeks before the survey to see whether or not they'd had at least 12 weeks of symptoms. And the main finding here was that 37.7%, so nearly 38%, had at least one symptom persisting for at least 12 weeks. So that's a huge proportion. And if you apply that to this everyone who's had symptomatic COVID-19, we estimated that about 2 million adults in England will have had some long COVID, if that's how you want to define it. This is just a graphs with on the left females and on the right males. If you just take for the females, this is the percentage of respondents. The top line is people with one symptom, and it shows the proportion with one symptom who were answering this question this number of weeks following their COVID infection. So this dotted line is 4 weeks and this is 12 weeks. So you see at 4 weeks, well over 50% of women had at least one persistent symptom, 2 persistent, 3, 4, and then 5 persistence. It was still about 13% of women with 5 persistent symptoms for 4 weeks, going down to about 8% for 12 weeks. After 12 weeks, you see very little decline. So people who had symptoms up to 12 weeks, they seem to persist for, we followed this out to 5 months. In men, you see a very similar pattern, but with a lower proportion, a lower prevalence for each of these with numbers of symptoms. This, won't have time to go into too much detail about this, but this is symptom persistence. So how long did they last? So tiredness is the one that persists most. You see most people have it. So the darkness of the blue is the proportion of respondents who reported that symptom for this number of days, right up to 150 days. So most people had a lot of tiredness at the beginning, and many, many people still had tiredness after 5 months. And then the others that we noticed, the shortness of breath, muscle aches going along, difficulty sleeping. So quite a range of different symptoms that persisted. We asked about additional symptoms in addition to the ones there. So I'll just go back to that. These are the symptoms that we asked about. These were actually symptoms derived from acute COVID, the kind that were common with that. We knew that there would be other symptoms, so we asked people to write in other symptoms they had, and then we basically looked at the words. There were, thousands and thousands of these, and we just did a word where there were co-occurring words, and it quite clearly shows the additional symptoms of long COVID that we hadn't included in that early questionnaire. Hair loss, high blood pressure, is brain fog, heart palpitations, severe joint pain, and then cough, shortness of breath, and loss of sense of taste or smell are ones that were in ours but were still mentioned by people. They obviously think they're important. So the fact of who gets, or what factors are associated with getting persistent symptoms, we've already mentioned that females. So this is a plot of odds ratio. So how much more likely are you? So the dotted line is there's no difference. So here we've got females are about, it's an odds ratio of 1.5, so about 50% more likely to report persistent symptoms. Interestingly, as you get older, it increases. So those over 65 and over 75 more likely to get it, and the younger people less likely to get it. We found a lower risk of long COVID in Asian populations, which contrasts with a higher risk of COVID itself. Higher risk in cigarette smokers or vapors. A higher risk in people living in deprived areas and who had low household incomes. Higher in healthcare workers, and much higher in people who'd been hospitalized, so had severe COVID. This is a very complicated slide, quite pretty, I think, slide. And this is using unsupervised machine learning to do, well, that's not true. This is using some kinds of machine learning to do clustering of people by their symptoms. And I'm just going to focus on the second half, so the L1 and L2. These were the two stable clusters of people with symptoms that were still present at 12 weeks. L1 was dominated by tiredness. I think we saw before, so tiredness, but with quite a range of other symptoms, including difficulty sleeping, headache, muscle aches. The second cluster of people were more likely to report respiratory symptoms, particularly shortness of breath, tightness of chest, chest pain, also fatigue and tiredness, but not quite as much. So this may start to indicate different syndromes that are going on, which this respiratory may relate to underlying damage to lungs, which is taking longer to recover. So in summary of this research, nearly a fifth of the population self-reported COVID-19, and a third of those with symptoms had symptoms for 12 weeks or more. So that means that 5.8%, so almost 6% of the whole study population had COVID, which lasts with symptoms for 12 weeks, which corresponds to the 2 million people in England. Persistent symptoms increased with age, women, smokers, overweight and obese individuals, and with deprivation. Also, I had put it on here, but with other comorbidities. And we conclude that managing the long-term sequelae of SARS-CoV-2 infection will remain a major challenge for health services in the next stage of the pandemic. So we published this last week, and we got very extensive press coverage. And I think it's interesting. I think this really strikes a chord with people, because a lot of celebrities, a lot of people have reported this, and yeah, I think it is a health problem, and it's affecting a lot of people. So I just wanted to pause again to see if there were any questions, further questions, or you're all still being very, very quiet.
I don't see no hands raised, no questions in the chat. Don't hesitate. The floor is yours. Well, I was wondering, you've got quite a lot of information. It's very inspiring, quite frightening as well. What are you planning to do with all this information, and how will you manage to use it in your online symptom challenge?
Yeah, so what we're going to be doing going forward, which I'll show you about next, is well, first of all, we want to add to the raising awareness, which I think, the patient groups have started, and with this publication, we've continued to raise that awareness of the scale of it, and to lend weight to the advocacy for services and for support. For example, speaking out to say that healthcare workers who've acquired COVID at work, this should be seen as a work-related illness. Things like that, I think, are quite important that professionals as well as patients speak out about that. But we are now, and I'll very briefly describe the research that we're doing going forward, and but we're very, very keen to continue to gather and, if you like, merge this very large research study that we've done, but with continuing to get very direct experience from patients. So we want to continue that partnership in influencing our research. So if there are no questions, what I'll do is I'll just do the last section of this, which is about how we're going to try and do that. And I really would then appreciate any feedback that people have. So the next phase that we're doing at the moment is called, it's separately funded, but based on this REACT study. It's called Reactancovid, and it started in April, really, this year. And our aim is to understand the natural history and long-term outcomes of infection, in order and characterize genetic, biological, social, and environmental signatures and pathways to underpin progression to long COVID. So the outcomes we'll be initially looking at are the symptom profiles, the experience of people, and the prevalence of long COVID, and then differences in biological pathways in people who have long COVID and not. And we're basing this on the REACT study, because through the REACT study, both the one where we were measuring virus in the community and where we were measuring antibodies, we have got a sample of people who we know have had COVID and who haven't had COVID, or who didn't at that point have COVID. And it's a random sample of the population that we hope to use for this study as well. I won't go right through this, but essentially what we're hoping to do is identify 30,000, so take a sample of the all REACT participants, 30,000 of them who've tested positive for coronavirus and either the virus antigens or antibodies, and recruit 4,000 with long COVID and 4,000 without. They are already being recruited to clinics where we are taking blood samples and doing various tests to see what their functional capabilities are, but also looking at their immunology. We'll do genomic studies. So multi-omic studies, we say, basically inflammatory biomarkers, genomic tests, and to look in detail for the genetic and biological risk factors that might distinguish people with and without long COVID. We will also be following up 120,000, some with and some without COVID, to look at their current symptoms, because some of the symptoms of long COVID or persistent COVID symptoms are very common symptoms like headaches, tiredness, difficulty sleeping. So we want to look at how those vary between people who we know to have had COVID and people who we don't know to have had COVID, or have no documented evidence. And we are also going to do in-depth interviews with people with long COVID, people without long COVID, and some environmental analysis to see whether there are other environmental factors that might influence this. So it's a very extensive, large study over the next 3 years. But what I wanted to finish this session on really is, because we're talking about patient experience and shared patient experience, to say something about how we, in my group, have involved patients. Apologies for my dog barking in the background, if you can hear her. So this is over the last year, and how we have tried and I think succeeded in involving patients and the public in our work. So this is just some numbers that we put together. So we, overall, nearly 20,000 members of the public have been involved in we've got a small number who are regular advisory group members. And so they are people we work closely with, who check documents we're using for research and look at our questionnaires and our study designs. And they come to meetings where we, every 2 or 3 weeks, we discuss what the research is doing, and they provide guidance and questions, and they're like critical friends to us, and they are absolutely brilliant people. So 7 of those have been involved since May or June last year, and then 4 have been specifically recruited with experience of long COVID. And nearly 400 others have been engaged and involved in other ways by us asking for their feedback on the kind of materials we produce, or asking their opinions on the kind of work we do. We also have a young people's advisory network that we consult around a lot of our research, because many patient and public involvement, or many of the patients and the public who get involved in this kind of work tend to be older. So we really work hard to get a young people's advisory group. And we did a special survey of parents and carers on the acceptability of this kind of study in young children. And then 14,000 members of the public were involved in a study where we actually asked about how usable these home test kits were. So that was a research study, but we were really interested in the acceptability and the usability of home testing kits for antibodies. So it's been a lot of people influencing our work. The original aims were to help improve the user journey and the experience of taking part in our research, to improve accessibility and understandability of study materials and our communications, and to support diverse engagement and involvement. And we work quite hard to try and make our work accessible to a wider range of people. So it started, our journey started with a call. So these, which was on the 1st of May, 2020, we had a Zoom call with people from across the UK to talk about at-home antibody testing, to design the whole REACT study. So this was one of the first activities we took. So we've had huge input into this. And one of the early questions or issues that was raised was about ensuring that the design would enable Black and minority ethnic representation, and that we were very clear about our data sharing. We then had a series of Zoom calls, and from those we produced rapid insight reports, which are available on our website. And later on we published papers. There's one recently in Nature Communications, which focused on structural inequalities during the first wave of infections. And I think our focus on inequalities has been really pushed by the fact that patients and public have been involved. The real world testing, it was actually a weekend where we sent out the test kits that were being used to a couple of dozen members of the public. Well, a bit more, 37 were in that. And then we had more people, some of whom we interviewed, who'd taken the test, and they told us how easy it was, how difficult it was, what needed to change, how the instructions needed to change. And also they advised us to do work on how you understand and interpret the results of antibody testing, which then informed our communication strategy. And then we did this very large usability study, which I've just described. Then we formed the public advisory group on sort of at the end of that month with these 8 public members, which gives us continuous guidance and feedback. So very finally, we are through so that was the REACT program in general. Now onto the long COVID new study that I described. We want to make sure that we keep that engagement going on. So our first thing here was at the end of April, when we organised a webinar about long COVID research, where we got, I think 70 or 80 people who came to listen to us talk about our research, and many of those sort of signed up for more ongoing involvement. We have also set up a thing called the COVID-19 Community Network, which we're doing in partnership with some people from the Long COVID Support Group. And this is on a platform called Voice, which is an online platform for involving members of the public in research in health and others. And Voice was set up by Newcastle University, and it offers the opportunity for doing a lot, both to advertise involvement opportunities, but also for doing surveys, for having discussion groups and really influencing research. And so we're setting up this group. And the first challenge that we've put up on there is defining long COVID symptoms, because many of these symptoms, like brain fog, are not very easy to communicate. So we wanted to try and get input from people with experience of that, to say, what does it mean to you? Which could then perhaps be turned into more visuals to share with a wider audience, because whether or not children understand the concept of brain fog, or people from different cultural backgrounds or education backgrounds. So try and have different ways of communicating what symptoms might mean. This is not our work, but this is somebody who's also been working on this, Monique Jackson, who tries to draw her own symptoms. What are they? White cold tips of your fingers, skin rashes, etc. We have just started this, and we have had some responses already. So, for example, pain. My body feels as though my joints are being smashed with a sledgehammer. The brain fog, being unable to say common words. I can visualize, but it won't come out of my mouth. Forgetting lots of things. Try to use a laptop, too many buttons to distract. Fatigue, feels like you wake up like a hangover every day. It's an exhaustion I've never known before. It can't be solved by sleeping 10 hours or having naps during the day. And air hunger, so this breathlessness is not just feeling a little short of breath, but it feels like your automatic breathing isn't enough. You aren't getting enough oxygen and you have to override it by breathing deeper while trying to keep calm. And I think these are very powerful, and we will use these to share, including with clinicians, to try and get clinicians to understand what it is that their patients may be experiencing. We're facilitating further involvement through the Voice online platform, these citizen science challenges, online discussions, workshops, and then hopefully co-creation activities and co-designing services and so on. And we will inform people who join those things about our research. We will have live stream webinars, Q&As, and blogs to try and communicate our work. So in conclusion, I think what this and what everything I know that the shared parent-patient experience colloquium is trying to do is really, we're trying to, as researchers, still challenge the dominance of the medical model. And there was a very interesting and thoughtful blog that was in the BMJ this month. And we know from what I've just said that patients report being dismissed. Many clinicians and researchers ignore the testimony of patients. And patient-led research, which many of these people have done, is often seen as unscientific and not very worthy. And Chu Graham and colleagues describe this as a form of structural iatrogenesis, where patients are harmed by power imbalances in the bureaucratic and cultural systems within medicine. And I think this sort of concluding part, what they say, is worth reading in full. Knowledge production in this new condition of long COVID must therefore involve and engage patients and the public, not only to ensure co-production of knowledge, but also to avoid top-down hierarchical service provision, which may make logical sense to people who may never have experienced the condition, but will be totally inappropriate to those affected by long COVID. Ultimately, toppling endemic power imbalances in medicine requires the input of people who have experienced the cognitive dissonance of confronting personal and healthcare structural biases, so that those providing healthcare fully comprehend the lived realities of the individuals they seek to serve. This is work that cannot be avoided. So finally, my acknowledgement. Public advisors, Margaret O'Hara, one of the founders of the Facebook long COVID patient group, Phil Prestera, who did a lot of these slides and who is our PPIE lead and works on the Voice platform, and Emily Cooper, who's a qualitative researcher, Matt Whittaker, who did the long COVID analysis, and Paul Elliott and Graham Cook, my co-eyes on the project, Nisreen Alwan, who was on that video, and Lynn Corner, who leads Voice Newcastle, and funding Department of Health and Social Care. And actually, we had amazing support from a logistic partner, Ipsos Mori, who sent out all those kits and helped us get data from 2 million people. Thank you.